the idea behind dragging you down here, Rachel, on a day that she is getting chemo later. She rescheduled her chemotherapy to come do this. Was to put a personal face on this process, because this, at the end of the day, this is about the patients. And the goal is to improve and significantly impact patients' lives at the end of the day. That's what this is about for me. Just taking the tumors out and giving chemo and then, giving up if it doesn't work for me.
Me either.
And this is very much about trying to change the paradigm, I think, about how we handle cancers in general. But it's easy to get lost in the data or the studies or even on an individual basis. But at the end of the day, it's about people. And for me, those pictures of you getting remarried in Hawaii were incredible. Because I'm not sure if you realize it or not, but you would, in my opinion, you wouldn't have gone if you didn't get that drug. And you got the drug because of the model, pure and simple. And we learned about that particular drug and your current treatment, and we'll continue to learn about more drugs as well. So I think it's easy to get, the patient can get lost in this process. And I think that, at least in terms of the company, I want it to be about good science, but at the end of the day, I want it to be about the patients. I don't want it to be a company that takes advantage of patients. I want it to be a company that helps patients. And it can be done, and we are doing it. And this is our first go at this, really, and the successes are startling. Arun, you can remind me, but I think Rachel's was the 8th PDOX, right? The 8th case?
Yeah, you were number 8, lucky number 8. And your case is a very special case because you have a very rare version of a tumor. For Ewing sarcoma across the world, it's treated in a particular fashion. And in cases like yours, where you had a rare mutation, oncologists are really not sure exactly what the best drugs for you are. And as you mentioned, we treated you with the standard Ewing's sarcoma regimen because that's all we know, okay? And for your really rare case, we don't have enough data. We haven't seen enough patients to really figure out what are all the best drugs. So in the case where the PDOX model, we could use that, we learned quite a bit about this disease. And all the other patients out there can also benefit from this information as well, because we've published that information. So not only did your experience really help you to find drugs to fit your case, but it teaches all the other oncologists out there who will come up with this case again in the future, hey, there are some other things that are outside the box, not traditional therapies that we would use, that other patients can benefit from. And that's another part of all of this, is to really help everyone out there who is going through these rare diseases. Having these models is really is good for not only for patients but also for oncologists, because these models, we can take them out of the freezer, we can grow them back up in 2 years, 5 years, whenever that time may be, and we can test the new drugs that are going to be available in the future. As time goes by, science improves, drug companies make better drugs, and in the future, if we can test to see what are the best drugs to use for individual cases. Today, for any given cancer, there's a certain amount of drugs that we can use. But after that, it's not clear when people progress through all the standard treatments, what do we do next? We've been lucky that in this era, there's a lot of genomic testing and new science. So we're learning quite a bit more about cancer, and we're finding new clues on how to treat them. But therein lies a real conundrum, is that, well, if we have 10 different options, which one are we going to pick? Because, when you find mutation data about tumors, it doesn't say, which one of the mutations are really important. Some are just what we call bystander mutations. They don't really contribute to the growth of tumors at all. It's actually the things called driver mutations that are very important. And the PDOX mouse allows us to test drugs against all the different mutations that might be found in a person's tumor, not just now from the science that we know now, but in 5 and 10 years, there's going to be newer and newer ways to do mutation testing, and we're going to learn so much more. But with more information comes a real problem, is how do you sort out and find the right types of treatment?
The genomic testing and all that, it gives you a whole bunch of ideas. It doesn't tell you what works. And the way to test it is in the patient, and they have X amount of time. So they don't have the time to waste on drugs that aren't working. It's just not possible. And, I think the other flip side to the story in your case, we were fortunate to find 1 or 2 drugs of the newer kind of targeted novel drugs that were effective in your tumor. But we also found out that the standard chemotherapy that you were getting was not effective. Now, you got the standard of care, but if we were able to trust the mouse data or get more of it, then I think it's just as important for a patient not to get a toxic chemotherapy that is not working on your tumor. I don't know if you want to comment on that at all, Rachel.
Let's just say that those 15 rounds were not the best months of my life or year of my life. It was, it was rough, and all chemo's rough. But then to find out that we actually had the data to show that I didn't need to go through that.
Well, but it's,
and at the same time, the data is also giving me what does work, and I get that now. So, the fact that I can be in extreme pain and start chemo today for every day this week and be out of pain is pretty darn amazing.
Yeah. Well, I think in the future, hopefully, with more cases like you, and we continue to publish, people will actually act off that mouse data, and then we could have pulled that at an earlier time point in you.
Yeah.
So that is one of the many goals of, at least for me personally, this project it's not just identifying new therapies for people, but it's also to prevent people from getting toxic, expensive chemotherapy that is not working on their tumor. So why do it? I think that's almost as important.
It seems like it would be really important for people who are on Medicare, because their costs are so much higher for chemotherapy if they don't have gap coverage. And so if you're able to identify and pinpoint what's going to work for them, especially for seniors, they can't afford the $2,000 copay or whatever it is. They want to be sure that if they're paying that, it's something that's going to work.